Good evening, everyone. Dr. Jared Ament and me, Dr. Amir Vokshore, another NSG Fireside Chat. Today, we wanted to emphasize the capabilities that we have, including telehealth and teleneurosurgery, and also talk about how do we really transition back to normal after the pandemic is, at least the first wave of the pandemic is over.
Yeah, so teleneurosurgery, telemedicine is not actually new, but the ability with technology to interact with our patients, even do physical exams, part of our physical exams at least, over the internet and online, it has never been better.
What do you think is like is a typical neurosurgical case that post-COVID is not going to be treated exactly the same? Is it a cervical disc herniation, a lumbar disc herniation? Where do you think that the line will be drawn where a case is going to be treated with conservative care even more aggressively than before prior to resorting to surgery?
I think as we transition back to normalcy, you posed the question and I would answer. I said, I really don't know yet. I think that we would
It's a
continue
fluid
to.
situation.
Yeah, it's a fluid situation. We should continue to manage things with conservative care as we're able. But as you and I have discussed before, pain is one of the most common things that you and I both deal with in our office. And it's extremely subjective. Some people's pain is truly an emergency. They cannot function, they cannot live, they cannot care for their loved ones, they cannot work, and they're debilitated. Their quality of life is truly affected. Others get extreme relief, get wonderful relief from an injection, from good pain management, from physical therapy.
You're a spinal deformity surgeon, and your expertise are in diagnosing patients that have three types of pain, four types of pain. There's a skeletal pain. There's a loss of spinal balance pain when somebody is just leaned forward and their muscles are fatigued and their sacroiliac joints or their lower lumbar joints are under severe strain. Then there is pain from stenosis causing them not to be able to walk well, or a severe pinching of a single nerve root, which gives you sciatica or extreme nerve pain. So your talent is to really sort out these different types of pains. And my question I want to pose to you, and we can certainly take it to another session, is whether you would opt for a much smaller surgery because of what's going on at the hospital, potential need for ICU care, transfusions, et cetera, and do a much smaller surgery in general.
That's a great question. I think we should definitely table that for the next Fireside Chat and talk about spinal deformity surgery post-COVID. It's going to be a really interesting question. I'll pose a question back at you also. What do you think are our limitations in telehealth, teleneurosurgery? Because I, for one, feel like seeing someone walk via telehealth gives us a lot of information, but we still clearly are limited. We can't touch, we can't do the actual physical exam. So in your experience, what do you feel are the limitations? And how do you reassure patients that are coming to see us about those limitations and how we can get around them?
I would say there's a lot of information that is subtle that us as clinicians are trained to pick up on, about a way a patient enters, about a way a patient squeezes your hand. So motor examinations, sensory examinations, reflex examinations are limited. So teleradiology is probably the most important part of teleneurosurgery because we're so imaging dependent. And we don't look at the images like a radiologist. We look at the images like a surgeon because we are able to correlate the images to what the patient's clinically experiencing, which I think sets us apart. And our colleagues have done this in telestroke, et cetera, well for quite a few years. And I think we need to get teleneurosurgery to the point that we are able to guide our patients accordingly. And I think in the past few weeks, we've experienced a significant uptick and have gained a lot of confidence in being able to do so with our patients.
The last question would be, is there a situation even during this coronavirus pandemic that you would absolutely insist on seeing a patient in the office versus bringing them to the emergency room, all of which are associated with a certain amount of risk, obviously? Because I've had a few patients, new patients, I've never met them before, that have really been quite insistent on coming to see me despite everything going on.
Yeah, I mean, the two things, an infection, that you're suspecting an infection, sometimes I think that patient needs to come to the emergency room. for discitis, osteomyelitis, epidural abscesses, even soft tissue infections, asymptomatic spinal stenosis that's quite severe on imaging, and it's in the cervical spine, and the patient's just anxious to know whether they need to be considered for surgery. If there's critical spinal cord compression, I think many neurosurgeons just look at the MRI and say, you need surgery. But there is a subset of those patients, and there's a lot of data that shows there is a small subset of patients, even in that arena, that remain asymptomatic and don't become symptomatic. Those are the patients I would like to follow very closely, and preferably with an in-office examination.
I think that's very helpful. Well, thank you for joining us for yet another Fireside Chat. We will continue to have more. Hope everyone's staying healthy and safe.
Stay safe, you guys, and we're available for teleneurosurgery.